Hello guys, so let's discuss today's questions from today's quiz, LIDS, LACRIMAL and SCLERA quiz. Are you all there joining? So today's quiz was actually pretty easy one. Alright, so we will start with the first question. Which of the following is or are modified sweat glands? So today's telegram quiz question. So gland of Zeiss is a modified sebaceous gland. So that's not the answer. Gland of mole, yes. Tarsal gland is meibomian gland, which is a modified sebaceous gland. And there was this very cunning answer that I've given. All of the above. So very many of you have marked all of the above. How, yeah? Gland of Zeiss and gland of that meibomian gland are modified sebaceous glands, no? So they can't be. So all of the above cannot be the answer at all. So modified sweat gland is gland of mole. Okay, so there are two glands opening into the eyelash. That is gland of Zeiss, which is a modified sebaceous gland, and gland of mole is a modified sweat gland. So take the M and put it, invert it, so you get gland of mole, sweat gland. Okay, and sebaceous gland is present within the tarsal plate. It is a vertically oriented gland and that produces sebum. So it is a modified sebaceous gland. So gland of Zeiss and meibomian gland, they produce the oily lipid layer of the tear film. Okay, the outer lipid layer. So can we move to the next question? Okay, so the question should have actually been most common cause. Okay, most common cause of keratoconjunctivitis sicca. That is dry eye, which is rheumatoid arthritis. So actually the answer is secondary Sjogren's, and the most common cause of secondary Sjogren's is rheumatoid arthritis. So indirectly rheumatoid arthritis is the most common cause. So that's a one-liner. Now most common complication of nevus of aorta. Now this is again very tricky because option A said blue sclera and most of you have marked blue sclera. See, blue sclera is not a complication of nevus of aorta. It is a finding that is seen in nevus of aorta. Okay. So that is option A, which is not the answer. It's not a complication at all. It's just a finding. Then choroidal melanoma. Yes, it is a complication of nevus of aorta, but the question says most common complication. Most common complication is not a malignancy. It is a secondary glaucoma because these melanocytes will go and block the trabecular meshwork, causing a secondary open angle glaucoma. Okay, so the most common ocular complication of nevus of aorta is glaucoma. And some of you have marked scleromalacia perforans. Why scleromalacia perforans in nevus of aorta? Nevus of aorta is just a hematoma involving the melanocytes in the sclera. Where do you find melanocytes in the sclera? In the innermost layer of the sclera. And what is the name of that innermost layer? It's called lamina fusca, right? Clear? Okay. Now ciliary staphyloma may occur in corneal perforation. Corneal perforation, what type of staphyloma you'll get? When the cornea bulges, you'll get an anterior staphyloma. Perforated corneal ulcer, again no, you'll get an anterior staphyloma. Scleromalacia perforans, correct, most of you have marked it correctly. Myopia, you'll get either an equatorial staphyloma or posterior staphyloma, because most of the times in myopia, and especially pathological myopia, it is a posterior segment which is elongated. So you will have staphyloma in the equatorial region and posterior region, not in the anterior to the equator. Okay. Now complication of lid coloboma, again a previously asked question. So when you have a lid coloboma, there's going to be lag of thalmos, and because of that, lag of thalmos means inadequate or incomplete closure of the eyelid. Okay. So because of the lag of thalmos, there's going to be exposure keratitis. So complication of lid coloboma is exposure keratitis. So I remember there was a previous year question of the same type, but it was an image based question. So here I've actually given it as a worded question. Which of the following is myogenic ptosis? Again, most of you have got it wrong. Third nerve palsy, it's a neurogenic ptosis. Yeah, okay, that's right. Myasthenia gravis is a disorder of the neuromuscular junction and it is considered a neurogenic ptosis, not a myogenic ptosis. Horner's syndrome, because the Muller's muscle is affected, because of ocular sympathetic palsy, that again is a neurogenic ptosis. Now the last answer, congenital ptosis. Hey, congenital ptosis is the most common cause of myogenic ptosis, although it is congenital. Okay, it's not an acquired form, like unlike your Kearns-Sayre syndrome or myotonic dystrophy ptosis. But overall, most common cause is congenital ptosis, and this is myogenic ptosis. Hi, Jack. All right. Okay, so most of you got it wrong. You all marked myasthenia gravis. No, myasthenia gravis is a neurogenic ptosis, and myasthenia gravis is the most common cause of bilateral ptosis. Which muscle is affected in myasthenia gravis? See, all the muscles are affected. Most commonly, or the first muscle to be affected in myasthenia gravis is your medial rectus. Yeah, medial rectus. And the tendinous muscles are less affected. So first, most common muscle is medial rectus in myasthenia gravis. Now, management of congenital dacryocystitis in a 2-year-old child, most of you got it right. See, birth to 11 months, congenital dacryocystitis or congenital nasolacrimal duct obstruction, you will do lacrimal sac massage and put topical antibiotics. Now, 11 months to 4 years, you will do the syringing and probing. Okay, you will do the syringing and probing. So this question asks about 2 years, 2-year-old child. So it is going to be syringing and probing. After 4 years, it will be dacryocystorhinostomy surgery. For ptosis, obviously it's LPS, no, Chirag? In myasthenia gravis, which muscle is affected? For ptosis, it is LPS. Okay, yeah. The muscle implicated in the ptosis of Horner's syndrome, this is a previous year question. It's very simple. Horner's syndrome is an oculosympathetic palsy. So sympathetic innervation is to which muscle? That baby muscle, the Muller's muscle, which is contributing to just 2 millimeter of upper eyelid elevation. So that's why you get a mild ptosis. Only mild ptosis you will get in Horner's syndrome. Okay. So the muscle implicated is Muller's muscle. And some of you, Mahan Log, have marked Horner's muscle. Horner's muscle is a totally different muscle. They will not ask you at your level. And frontalis muscle. What? Yeah, frontalis. Come on, guys. Okay. Now, and the surgery for Horner's ptosis, Fastenella Servat surgery. Alright? Okay. Now, which of the following drugs increases tear production for dry eye? Those of you who watched the evening video, 5 p.m. live session, you marked it correctly. The Acoltremon, I told you, Acoltremon is a new drug, the latest drug in ophthalmology, which was approved by the FDA in May 2025, Acoltremon. Now, Acoltremon is a TRPM8 receptor agonist, which increases the basal secretion of tears, and it is used in the management of dry eye. Now, this last question, it showed an image. So, the image, if you see, you have eyelashes arising from the meibomian gland orifice. See, this is the normal lash. These are the normal lashes from the anterior part of the lid margin. Now, you also got some from the meibomian gland orifice. So, this is a meibomian gland metaplasia, which is distichiasis. This is not trichiasis. Trichiasis is when you have an entropion and the normal eyelashes are misdirected. That is trichiasis. This is not trichiasis. This is distichiasis. Okay. Not ectropion. Obviously, no ectropion. The lid margin is absolutely normal. No trichiasis. Not trichomegaly. Trichomegaly is long and thick eyelashes. Yeah. Yeah. See, myasthenia gravis, beta, striated muscles. Your Muller's is not a striated muscle. Muller's is sympathetic innervation. No? So, Muller's is not at all affected in myasthenia gravis. Simple, common sense. We've learned in first year, no, the fibers. So, this is a, LPS is a striated muscle, and myasthenia gravis affects the striated muscles. So, it doesn't affect the Muller's at all. So, it will affect the LPS. Okay. So, any other questions that you want to discuss regarding our lid lacrimal sclera quiz? Okay. So, I think it was a short and sweet discussion, well under 10 minutes. All right. So, Saturday, it's really good that still some of you are up and about. So tomorrow, I forgot what is the test for tomorrow. Okay, so tomorrow's quiz. So join the Telegram group. You'll know the schedule. So tomorrow we will see again, probably 5 p.m. I don't know. Tomorrow's Sunday. Let's see 5 p.m. if we want a live. Definitely 9 p.m. we'll do a discussion of the questions. I hope this is helpful for you. All right, guys. Chalo. Bye, all of you. Good night.